Peculiarities of the heart and the cardiac cycle. The heart consists of cardiac myocytes. Myocardium consists of the special type of muscle tissue which is called heart muscle tissue, and it has some properties that also may be found in the muscles, like smooth and striated muscles that we know already. And these properties are such as contractility, conductivity, excitability, of course, etc. And there are some peculiarities that distinguish the cardiac muscle from the rest of the types that we know. And these peculiarities we should know. The first peculiarity is the cardiac tissue, muscle tissue, consists of separate cells, not fibers like striated muscle. But these cells, cardiomyocytes, are connected very tightly into the common net by such cross bridges, by electrical synapses, in fact, nexuses. And as a result, the cardiac muscle contracts as a single common unit, and excitation is spreading in all directions from the area where it was produced. It was proved in the special experiment where a piece of cardiac muscle was taken and such cuts were produced like labyrinth, and when excitation was given to the one corner of this piece of the muscle, cardiac muscle, the excitation was very rapidly spreading in all directions and was very rapidly, the whole piece was involved in the process of contraction. So the first peculiarity is that it is a pseudosyncytium, as we call the cardiac muscle. The second peculiarity of the heart is all or none law. So the heart obeys all or none law. What does it mean? It means that in the response to threshold or over threshold stimulations, the heart contraction reaches maximal extent. So under threshold, no contraction. Threshold, we have maximal response. When we will increase the stimulation, still we will have the same maximal contraction. Third peculiarity of the heart is Starling's law of the heart. Starling law. It means that the more is the expansion of the heart with the blood, the more is filling of the heart, the stronger is contraction. And it's very good because the more is the input of blood in the heart, the stronger are the contractions. There is some limit. If the filling of the heart will exceed some high level, then the increase of filling will not lead to the increase of the strength of contraction, but vice versa will decrease the strength. And in the clinical practice, it indicates the decompensation of different pathological processes in the heart. So Starling law, the more is filling, the stronger is the contraction. The fourth peculiarity is that the tetanus is not possible in the heart. So it's good, of course, because tetanus, the tetanic contraction will indicate that the circulation will stop. But we should know the mechanism of it. So to explain it, we should draw the action potential of so-called typical or working cardiomyocyte. In fact, cardiac muscle consists of three types of cells. We have typical, or they may be called working. The majority of cardiomyocytes are just typical or working cardiomyocytes. And action potential is produced in the heart in atypical cardiomyocytes. That's why they are called cardiomyocytes of the conducting system of the heart. So typical cardiomyocyte action potential looks like that. So the resting membrane potential is about minus 90 millivolts. 0 is here. What we see here is a long plateau phase. Plateau phase prolongs this action potential significantly. And this plateau phase is explained by the prolonged calcium input, calcium influx into this cell. So the duration of this action potential explains the long refractory period. If we will draw the refractory period, absolute and relative refractory periods, then together they will produce 0.33 seconds. And it is also the duration of the systole or of the contraction of the heart, of ventricles. So the whole period of contraction, the heart is in refractory period, is inexcitable. That's why tetanus is not possible. Well, we explained the inability to tetanus. Tetanus not possible. It was the peculiarity. And the fifth peculiarity of the heart is automaticity. Automaticity. As we know, automaticity is ability to excite without any external stimulation. So the source of excitation is inside of the heart. And this peculiarity should be discussed in details, and to speak about it, we should say again that there is conducting system of the heart that is produced by atypical cardiomyocytes. Let's draw the conducting system of the heart. So we will draw the heart. When we draw the heart, we show the apex below and the base of the heart at the upper part of the body, and we draw the heart in such a manner that it represents the heart of our patient before us. So that chamber will be the right atrium, and that chamber will be right ventricle. So, and the left part of the heart, the opposite part, this is the left atrium or left auricle, the same, and the left ventricle. So the systemic circulation begins from the left ventricle by aorta, and from the right ventricle we may observe the pulmonary trunk, and to the right atrium vena cava superior and vena cava inferior, bringing the blood, and pulmonary veins to the left atrium. And we have valves. We have atrioventricle valves. Mitral valve is the left valve and tricuspid valve at the right part of the heart. And semilunar valve are found in the beginning of aorta and pulmonary trunk. Okay, just from anatomy. And now the conducting system of the heart by the blue color. So the most significant part of the conducting system of the heart is SA node. SA node is located at the right atrium, where vena cava inferior and vena cava superior are attached to the atrium. The second part of the conducting system of the heart is AV valve, AV node. AV node. It is located between the atriums and ventricles. From AV node, we may find the bundle of his bundle. It has two legs, right leg and left leg of his bundle, and Purkinje fibers, which conduct the excitation to the different typical myocytes in the ventricles. As we already told, the most important part is sinoatrial node, which is called also pacemaker of the heart. Pacemaker of the heart. So it is like a conductor producing the rhythm. The normal heart rate is about 70 beats per minute. So it is the influence of the pacemaker of the sinoatrial node. Heart rate is about 70 beats per minute. If the pacemaker loses its ability to produce excitations, then AV node may take this role, but its automaticity is approximately 2 times less than of the sinoatrial node. So it will produce only 35 beats, 35 excitations per minute. And also in clinical practice, artificial pacemakers may be implanted in the cases when the normal rhythmic activity of the heart is destroyed, and electric stimulation of artificial device will excite the heart when it is needed. To explain the activity of the pacemaker of the heart of sinoatrial node, we should draw the action potential of these atypical cardiomyocytes. So let's draw the graph. Time minus 60, the potential is higher than of typical cardiomyocytes, and what we see is the absence of resting membrane potential. Instead, we see slow diastolic depolarization, and potential is gradually increasing spontaneously, reaching the critical level of depolarization, or firing level, as we know. So when the firing level is reached, we see depolarization or repolarization, but as soon as the potential again reaches minus 60, it begins to increase, again SDD and again depolarization, and the whole life in such a manner the myocytes of sinoatrial node do produce excitations. What is the mechanism of SDD? It is the influx of sodium. So influx of sodium into these atypical cardiomyocytes. It is the influx of calcium, and it is the closure of potassium channels. So potassium is accumulated in this cell, increasing its membrane potential. And this property is genetically determined, and these atypical cardiomyocytes do explain the rhythmic activation of the heart. There is gradient of automaticity. This gradient of automaticity is the decrease of automaticity from the base of the heart to the apex. So the most prominent automaticity is found in the sinoatrial node, and in the apex the Purkinje fibers practically do not exhibit any signs of automaticity. And it was proved in the experiment with ligatures, so-called Stannius experiment with ligatures. So the ligatures are the small ropes which are laid on the heart. The first ligature was isolating. It was placed below the sinoatrial node, and if the cardiogram was observed before, and it looks like that, the systole of atrium, systole of ventricle, and then the common pose, it's the cardiac cycle. Then after the first ligature we see the straight line, because the cardiac muscle was isolated from the influence of sinoatrial node. The heartbeat stops. Then second ligature is laid accurately on the AV node. So the second ligature is stimulating, and it stimulates AV node, and after this ligature the contraction of the heart is initiated, but the frequency of contractions is 2 times less. So it will be about 30-35 beats per minute, and it proves that AV node exhibits less automaticity than sinoatrial node. And the third ligature is laid below AV node. It is also isolating. It is tightened strongly, and it isolates the ventricles from the influence of AV node. And again we see the straight line that proves that in the His bundle and Purkinje fibers there is practically no automaticity. So it shows and proves the existence of the gradient of automaticity in the heart from SA node. From the base of the heart to the apex, the automaticity decreases. And now we will speak about the cardiac cycle. To remember, we will draw a simple picture that will illustrate the consequences of events. So the duration of cardiac cycle, if the heart rate is about 70 beats per minute, then the duration will be 0.8 seconds. So every 0.8 seconds the events will repeat, and the cardiac cycle begins with the systole of atriums. So the upper strip reflects the events in the atriums, and in the bottom the events in the ventricles. So the first phase is the systole of atriums, and its duration is 0.1 second. So it is the systole of atriums, and excitation propagates to the ventricles after a short delay. But this delay is critical, because during the systole of atriums the ventricles should be in the relaxed state to be filled with blood. This delay is produced by AV node, and its duration is about 0.12, 0.2 seconds. So after the systole of atriums, the systole of ventricles begins, and its duration is 0.33 seconds. The systole of ventricles consists of several periods and several phases. There is asynchronous contraction when the separate cardiomyocytes contract but other do not, and at the end of that phase the AV valves close, and the period of isometric contraction begins when all valves are closed and the pressure in the chambers, in the ventricles, increases up to 80 millimeters mercury. At the end of that phase, the pressure in the ventricles becomes higher than in the large vessels. In the left ventricle, it's more than 80, more than in aorta, and semilunar valves close, and the period of ejection begins. The period of ejection duration is 0.25 second, and it consists of rapid ejection 0.12 and slow ejection 0.13 second. And at the end of the slow ejection of the blood, the common pause period, the third period of cardiac cycle, the common pause, the common relaxation, 0.37 second. Speaking about the diastole of ventricles, we should say that it lasts longer. It lasts 0.47 because it also is including the systole of auricles together. The period, the diastole of ventricles consists of protodiastole, the period of isometric relaxation, and the filling of ventricles with the blood, a rapid and a slow filling when the AV valves open and blood is filling the ventricles. The important parameter that characterizes the cardiac activity is the stroke volume. Stroke volume is amount of the volume of blood ejected during one systole from one ventricle. It is about 75 milliliters. It's approximately the same from the right and from the left ventricle. And the cardiac output is the volume of blood that is ejected from the ventricle per 1 minute. And to calculate the cardiac output, we should multiply stroke volume per heart rate. So it will be approximately 5 liters per minute, but it may substantially increase during the physical exercises, and it may reach 25 liters per minute easily to supply the body with nutrients and oxygen. Extrasystoles. Extrasystoles are preliminary heartbeats. They occur when additional excitation is given to the heart before the normal systole, normal contraction occurs, and they are divided into atrial and ventricular extrasystoles. So let's look at the atrial extrasystole. We have the normal systole, again normal systole, again, and then before the new one is produced, we see the abnormal heartbeat. So that is atrial extrasystole. And what is important? So the normal period, the 0.8, is between the atrial extrasystole and the new heartbeat. Another situation is with the ventricular extrasystole. Here we have the normal heartbeats. Okay, 3 normal, then ventricular extrasystole, and then we see compensatory pause. And only after this compensatory pause, the normal heartbeats continue. So this is compensatory pause. And this is the ventricular extrasystole. So it may be explained by such fact that when the additional excitation occurs in the ventricles, then pacemaker SA node is continuing to produce excitations due to its automaticity, but it propagates to the ventricles when they are in the state of the refractory period, and they are inexcitable, and that's why one contraction is missed, and only the second excitation from SA node may reach the ventricles and excite them. And this is the reason why the compensatory pause is observed only in the case of the ventricular extrasystoles.